evening, everyone. I hope I am audible. Hello. Okay. Thank you again for joining this webinar in such a short notice. So, yeah, as you all know, recently IDSA has released AMR 3.0. So, where they have updated the existing AMR guidance, I will say, guidance, where and they have updated, not major updates, but yeah, they have made significant updates. So that's why I thought I will have a webinar today. So we will start in another 5 minutes.
When have we put up the bus extra?
I request all of you to please stay muted.
खुद तरह का करो नहीं यार, ऐसे कीड़े मकोड़े करते हो, पेन मैंने कैसे होते कलेक्ट करे हुए।
मेरी पेन
हाँ,
मेरी जी करना
फुटा फुटा पेन तो संभालने खुद पड़ते, मेरे तो दुनिया थोड़ा छोटा
Okay, let's get started then. 6-5. Okay, I welcome you all of you again to the webinar. So today we're going to discuss the IDSA AMR updates. So I request all of you to stay in mute throughout the webinar. In case of any queries, you can put it up in the chat box. And whenever possible, whenever there are case scenarios, so I request all of you to actively participate. So without any further ado, let's get started then. So this is the IDSA 2023 guidance on treatment of antimicrobial resistance gram-negative infection, which was published on 7th of June this year. And it covers ESBL, AMC, CRE, Pseudomonas aeruginosa with difficult to treat resistance, crab, and Stenotrophomonas. I will try to keep it as short as possible. In case of time constraints, maybe I'll skip the Stenotrophomonas. I think most of us won't be dealing with that majority. So yeah, so there are certain important points which needs to be considered. This is just a guidance and not guidelines. So this can act as a stepping stone, like you can make your clinical decision based on this, and it's not necessary that you stick to this. And the guidance is mainly for the US based population, and that's why they've considered the epidemiology of the US. And this current guidelines is not based on the grade recommendations, and but instead there are 6 experts from IDSA who have sat together and had various meetings and made this guidance. And they recommend involvement of ID physician whenever gram-negative infections are suspected. And this applies to both adult as well as pediatrics, but the dosing of only adults has been provided in the guidance. And they have not commented on the empiric therapy. So whatever the case in the guidance is for the targeted therapy. That is once you have the antimicrobial susceptibility in your hand. And they have not made any recommendations for the duration of therapy. But they have made an important point that there is no difference between an isolate which is resistant and isolate which is sensitive. So the duration of therapy is based on the organism and site of infection and not based on the resistance pattern it is harboring. So most of the I had covered the very important points which will be required for understanding this guidance. One is the basics, beta-lactamases and newer BLBLI, as well as I had covered the previous IDSA guidelines and also compared it with the ECMED guidance. And the recent Pseudomonas in guidance interpretations I have discussed in what's new. So let's start this with a case. So here I have a 30-year male type 2 diabetes coming to us with fever, burning micturition, and flank pain. He's hemodynamically stable. So what is a provisional diagnosis? So there is fever, burning micturition, flank pain. So you will think of mostly complicated UTI and query pyelonephritis. So this patient was started empirically on ceftriaxone, and next day you have sent the urine culture as well as the blood culture, which shows E. coli. In urine, it is more than 10^5 with the following susceptibility. So what would you like to start the treatment patient on now? So because of certain issues, I couldn't link it with the poll. I request all of you to use the chat box. What would you like to give this patient? So the patient has the isolated ceftriaxone resistant, Piptaz SDD, carbapenem susceptible, cefepime resistant. So what would you like to give in this case? Piptaz, ask for amoxiclav susceptibility, nitrofurantoin, fosfomycin, meropenem, ertapenem, imipenem. What would you like to give? Meropenem, fosfomycin. Any more responses? Phospho. Okay. Meropenem. Okay, let's address each point in this. So this is why you need to understand how to interpret and culture report. So what are these jargons, ESBL, AMC, NDM, KPC? So I'm not going into detail of this classification of beta-lactamase, which I have already discussed in my previous webinars. And clinically important ones are your ESBL, AMC, as well as the MBL. And this is how, in brief, how you'll be recognizing whether it could be an ESBL, AMC, or a CRE. So important ones in this is as per the IDSA, as we all know, CLSI no longer recommends testing for the ESBL or AMC specifically. Hence, we have to rely on the culture report. So based on the report, you can predict. It's not necessary that it is 100% correct, but you can predict. So the one important antibiotic which you need to observe is the ceftriaxone. So if there is ceftriaxone resistance or the MIS is more than 2, you will be considering that it could be mostly an ESBL. Next important thing which you need to see is look for is your cefoxitin. So it is a good screen for your AMC production. So if it is resistant, it is mostly your AMC. And then obviously, if it is any of the carbapenem is resistant, that means it is a CRE. So in our isolate, if you go back, our isolate was resistant to ceftriaxone, piptaz, SDD. So this would most likely be your either ESBL with AMC or AMC. So coming to the guidance for the ESBL. So again, just brief, ESBL are the enzymes which inactivate penicillin cephalosporins as well as your aztreonam. In general, they remain susceptible to your carbapenem, and they are not inactive. They do not inactivate, meaning other non-beta-lactam agents can be active against this. But most of the time, these ESBL genes often harbor additional genes or mutations which will make the organism resistant to other drugs as well. And the most common prevalent ones of the ESBL is seen in your E. coli, Klebsiella, Proteus, etc. In India, most common can be CTXM. And as you all know, routine ESBL testing is not performed. So non-susceptibility can be used as proxy. But again, it's not 100%. So it could be because of many other reasons as well. So this has been brief, the guidance. So there is not much difference between the ESBL which has been considered in the current guidance. So for uncomplicated cystitis, nitrofurantoin or cotrimoxazole, alternatively fluoroquinolone can be used based on the susceptibility. Only in cystitis, you can use nitrofurantoin, and you can use fosfomycin, oral fosfomycin as an alternative agent. They recommend only for E. coli only, because other organisms like Klebsiella can harbor your FOS-A gene, which will render it resistance. So higher rate of resistance, and this what I'm talking about is an oral fosfomycin. There is the guidance specifically says don't give amoxiclav, because there has been study which was done in 2005 which was has shown that amoxiclav was associated with higher failure rate. And this amoxiclav I'm talking about in relation to the organism. So if the organism is ESBL-E, don't give amoxiclav, and not for it is not a general rule. So for enterococci, you can as well give. So next, if the patient is having pyelonephritis or complicated UTI, as is our case, 4-trimoxazole fluoroquinolone can be given if it is susceptible. Our case, it was resistant. So the next choice is your carbapenem. Alternatively, aminoglycoside can be used for the entire duration. And whenever there is pyelonephritis, remember there is no role of your fosfomycin, nitrofurantoin, and in general in UTI, doxycycline is not to be used. In infections other than your UTI, urinary tract infection, in infections other than UTI, you can use carbapenem. And again, remember, once the susceptibility has been given, like in a carbapenem, it is susceptible to ertapenem, imipenem, meropenem, you can always give ertapenem, which is considered as a first generation carbapenem, rather than treating all with meropenem. There has been trials which have shown that both of them are equally efficacious. And one more advantage of ertapenem is you can use it for your OPAT basis as well. One important thing which they have made note in this guidance is that if the important thing is ertapenem is equal to all are equivalent. If the patient is having hypoalbuminemia or if the patient is critically ill, go for meropenem or imipenem. And it's not that you treat for the entire duration you using the carbapenem. this guidance has specifically mentioned you can go for step down based on the susceptibility to cotrimoxazole or ciprofloxacin or your fluoroquinolones. Once the patient is hemodynamically stable, the susceptibility to these agents has been established. But do not use for step down nitrofurantoin, fosfomycin, amoxiclav, doxycycline, or omadacycline. So next important thing is what previous guidance and this guidance has also addressed this alternative therapy of ESBL. So as we all know, the Merino trial, piptaz versus carbapenem. So piptaz, can you give in ESBL or can you give cefepime? So the guidance specifically says that piptaz only in case of your if you're suspecting cystitis and you have started empirically on piptaz and there is a clinical response, you can continue. If but if the patient has not been started on empiric therapy, ideally should not be giving piptaz or cefepime in a patient who is having ESBL-E. While again, first thing is it's because of the Merino trial. Though the Merino trial they have de-analyzed and found that there is not the difference between the carbapenem versus piptaz was not significant, but there was numerically higher failure rate with piptaz when compared to that of the carbapenem. This could be because of the OXA1 co-production, and also one more issue is with the piptaz MIC. The automated systems may provide unreliable susceptibility results, especially if there is OXA1 co-production. Even in the cefepime, some of the ESBLs can hydrolyze cefepime as well, and the data is actually limited. There is no head-on trial which has demonstrated which was against cefepime versus your carbapenem, but there has been one propensity man's observational study which has showed higher mortality with cefepime other than when compared with your carbapenem. And the MIC testing also may be inaccurate or poorly reproducible when an ESBL enzyme is produced. Next, this is what they've added in this guidance this year is the role of cefamycins. So as I mentioned before, your ESBLs remain susceptible to your cefamycin, that is your cefoxitin as or cefotetan. So ideally you can use it for the therapy. There has been around 7 to 8 studies which have looked at the outcomes of cefamycin in ESBLE, but they have not differentiated based on the species and the type of enzyme. So, and also the dosing of your cefamycins and the availability of the cefamycin is an issue. So these are have very short half-life. So you have to give almost Q4-hourly or Q6-hourly. So until the other more clinical outcome data is available and optimal dosing has been defined, the guidance specifically says not to use cefamycin for ESBLE. Next, what they've added is role of newer BLBLI and cefiderocol in ESBL enterobacterase. So obviously these will have activity against ESBL-E, but we have to preferentially reserve it for treating infections caused in which like your CRE. One important thing they've added is not to use ceftazidime tazobactam in ESBLE because the tazobactam component, like just like your piptaz, so the tazobactam is not adding any further advantage, and this concerns with the inhibition of the ESBL production. So only in places where there is no other option and there is a polymicrobial infection, you can go for newer BLBLI, otherwise avoid. So next I have another case. A 65-year-old male presents with nausea, vomiting, diarrhea, fever for 1 week. He is on prednisolone and adalimumab for his Crohn's disease. On examination, he is febrile with hypotension with elevated counts. He was empirically started on ceftriaxone and vancomycin. Blood cultures were sent and it shows growth of your Citrobacter fluendi, which is susceptible to your ceftriaxone, cefepime, amoxiclav, basically pan susceptible. So what would you like to do now? So please use the chat box. So what antibiotic change would you like to do now, along with obviously stopping the vancomycin? Would you like to continue ceftriaxone, change ceftriaxone to ceftazidime, ceftriaxone to ampicillin sulbactam, ceftriaxone to imipenem, ceftriaxone to cefepime? So yeah, please reply in the chat box. Change to cefepime, imipenem, cefepime, imipenem. Okay. Ampicillin sulbactam. Okay. So let's address each point here. So what are the resistance which I'm concerned in this case? So I have specifically said the organism is Citrobacter cruendi. So now coming to the topic of AMC enterobacterales. So these are resistant to your penicillin third generation cephalosporins, including your cefamycin and BLPLI. Cefepime can be used and just like ESBL, it can be associated with resistance to other drugs. And this AMC can be inducible, stable chromosomal derepression or plasmid mediated AMC. So what do you understand by inducible AMC? So it means the organism is not constitutively producing AMC enzyme in the periplasmic membrane, but when exposed to the antibiotic, the enzymes will build up in the periplasmic space and hence will increase the MIC, leading to the resistance to your third generation cephalosporins like the ceftriaxone and ceftazidime. So, well, what is the clinical implication? It may appear to be susceptible in vitro. That is, when you are looking at the culture report, it can be susceptible. But once you start the patient on the therapy, the resistance is induced. Constitutionally, when the organism is producing AMC, it will be resistant even in vitro, and hence it will not pose a treatment dilemma. So, which enterobacterial should be considered to have to be at moderate to high risk of clinically significant AMC production due to inducible AMCD? Your Enterobacter cloacae, Klebsiella aerogenes, which was previously Enterobacter aerogenes, and your Citrobacter cruendi. So these are the three important organisms you need to consider. So whenever you change in a culture report Enterobacter cloacae, Klebsiella aerogenes, or Citrobacter cruendi, you should be very careful about using the antibiotic in this case. Even though your ceftriaxone is coming as susceptible, do not use it. So which antibiotics induce this AMC? So yeah, we have certain antibiotics which are strong inducers, which are weak inducers, and there are antibiotics which are good substrates. That is, the AMC will eat up these antibiotics very easily, and there are certain antibiotics which are poor substrates. So your strong inducers means these antibiotics, if you are giving in the patient, it will induce more and more AMC production. So substrates in the substrates are something. So the AMC enzymes will break up these enzymes. So your amino penicillins like amoxicillin, ampicillin, your first generation cephalosporins, including your cefamycins, are good substrates as well as strong inducers. So are you going to use it? No, never use these in case of patients having your inducible strains which are having inducible AMC production. Then we have weak inducers, which include your piperacillin, piptaz, ceftriaxone, ceftazidime, cefotaxime, aztreonam, but these are also good substrates. So strong inducers and poor substrates are your imipenem, and weak inducer and poor substrates is your cefepime and meropenem. So whenever there is a organism like such organism which that is your Enterobacter cloacae, your Klebsiella aerogenes, or Citrobacter cruendi, you should use a weak inducer and a weak or a poor substrate, that is a cefepime or meropenem can be used. In the carbapenem, imipenem is an inducer of AMC and hence it has to be avoided. So coming to the options, before we had discussed the question. Ceftriaxone, will you continue? No, you shouldn't be continuing. Ceftriaxone and ceftazidime both are good inducers, so do not use that. Ampicillin sulbactam, again, as I showed, ampicillin sulbactam can't be used. Imipenem, again, is one of the good substrates, so should not be used. So, ceftriaxone to cefepime is the correct answer. So, which antibiotics will resist this AMC? Your non-beta lactams like your fluoroquinolones, aminoglycoside, 4-trimoxazole, tetracyclines, basically can resist. Cefepime is a lower inducer but remains stable against AMC and hence can be used. So, what is the role of cefepime in AMC? So, cefepime is suggested to be used when the cefepime MIC is less than equal to 2, but when the MIC of cefepime is in the STD range, that is more than 4, between 4 to 8. So there are chances that the organism is co-producing ESBL, and ESBLs, you know, as I have mentioned before, the role of cefepime in ESBL is not clear and it should not be used, and hence a carbapenem is preferred in that. What is the role of ceftriaxone? Ceftriaxone or ceftazidime is not recommended for such AMC inducers because one thing, there is no CLSI defined criteria for AMC detection, coexistence of ESBL and AMC, and there is studies which have shown that on treatment there is increasing resistance. Ceftriaxone can be reasonable in uncomplicated cystitis, but again, better to avoid. So, what is the role of peptides in AMC? It is not suggested for serious infections, and tazobactam is less effective in against inhibiting the AMC hydrolysis. And there is a meta-analysis which again has proven there is though there is showing that it doesn't have a difference between peptide and carbapenem, but this was a very heterogeneous population and there was multiple confounding factors. It can be reasonably used if the patient is having uncomplicated cystitis. So what is the role of newer BLBLI and ceftriaxone? Again, the same thing. You should preserve it for your CREs. And again, there is a recommendation for not using ceftriaxone tazobactam in AMC. So next, talking about the carbapenem resistant enterobacteriales. So carbapenem resistance means resistance to any of the carbapenem. So this can be by two mechanisms, either carbapenemase production or not carbapenemase producing mutations like your porin mutations or flex pumps or other hydrolyzing enzymes. So your carbapenemase producing can be ideally it is divided into MBL and non-MBL because of the treatment variation. So your MBLs include your NDM, WIM, IM, SPM, GYM, SIM, etc. And then your class A includes your KPC, IMI, JES, and others are your OXA type, that is OXA 48 like OXA 72 and OXA 244. So whenever there is production of carbapenemase, they hydrolyze carbapenem, your broad spectrum penicillins, as well as your cefamycins. So carbapenemase, these are the important three groups which you need to be remember. You need to remember. So class A is your KPC, B MBL, and D is your OXA 48. So next important point you need to remember is substrates which can be inhibited. So KPC can be inhibited by avibactam, webobactam, and relibactam. Your MBLs is not inhibited by any of these enzymes, newer BLI enzymes, whereas OXA 48 is inhibited by your avibactam. So detection of carbapenemase, ideally the guidance suggests that carbapenemase detection should be done. So it can be done by various methods. I'm not going into details of this. So apart from this, we have the Carba-R test, which is a gene expert based carbapenemase detection, or we have Carba-5 test, which is a lateral flow immunoassay. So please respond. What are you guys using to detect carbapenemase in your institute? Please comment. Please leave in the chat box. Modified Hodge test, that is the most common. So lateral flow assay, any one of you using lateral flow assay? Which lateral flow assay are you using? Okay, so this carba-5, and now there is one more another lateral flow assay, that is your OK and IV resist 5 test, which detects your 5 important carbapenemazine, that is NDM, KPC, OXA48, IMP, and VIM. So this is the one which we use in our institute, and it's a very simple procedure of 15 minutes, and you will have the results, and quite cost effective when compared to your Carba R Gene Expert. So what is the preferred approach for treatment of infection of enterobacterials without carbapenemase production? So for this, you to decide this, you need to test for the carbapenemase first. So depending upon the susceptibility, if it is resistant to ertapenem but susceptible to meropenem and imipenem, is it a CRE? Yes. So according to the definition, resistance to any one of the carbapenem means it is a CRE. If there is no carbapenemase production and you are seeing such susceptibility, and the MIC is less than or equal to 1, you can use extended infusion in meropenem or imipenem. Next situation, we have CRE, no carbapenemase production, susceptible to your meropenem, but resistant to ertapenem and imipenem. For this, in this situation, depending upon the severity of the infection and the site of infection, if it is UTI, you can go for extended infusion meropenem. But in other infections like your intra-abdominal infection or bloodstream infection, avoid any carbapenems. So next, coming to the treatment of uncomplicated cystitis in a case of CRE, that is carbapenem resistant enterobacterias. So if susceptibility is demonstrated to fluoroquinolone, cotrimoxazole, or nitrofurantoin, it can be used. Single dose aminoglycoside is a very good option if the patient is having uncomplicated cystitis. If other drugs are resistant, so then you can go for the newer BLBLI like your ceftazidime, avibactam, meropenem, veborbactam, imipenem, cilastatin, and relibactam, cefiderocol. Fosfomycin, again, just like your others, you can use only in case of E. coli. Colistin is preferred in cystitis, not polymyxin B. In case of pyelonephritis or complicated UTI, same like if a non-beta-lactam like your fluoroquinolone, cotrimoxazole is susceptibility is demonstrated, it can be used. Otherwise, your newer BLBLI, there is no role of oral fosfomycin. Alternatively, aminoglycoside for the entire duration, that is around 7 days, can be used. So infections other than urinary tract infection, in this guidance, they have specifically based it on the type of the CRE, that is if it is carbapenemase producing, and it is you're seeing it as a KPC, which is predominant in other parts of the world, whereas in India we have predominant MBL production. So if it is a KPC, meropenem, veborbactam is preferred over ceftazidime, avibactam. Then last option is your imipenem, cilastatin, relibactam. Alternatively, cefiderocol can be used. If it is an MBL producer, ceftazidime, avibactam plus aztreonam can be used. And in this guidance, they have given in the, if you download the supplement section, they have given very well how you have to give various drugs. In this, they have clearly mentioned how to give ceftazidime, avibactam. It has to be given simultaneously with the aztreonam. So you can use it as a single infusion, or you can use it as a Y section compatible, so it can be used. So what is the use of aztreonam in MBL production? So ceftazidime, avibactam in MBL, as we have seen before, your MBL is not inhibited by your avibactam component. So this aztreonam can very well act in that situation, and that is why it is given as a combination of with ceftazidime, avibactam. If it is an OXA48 like enzyme, you can give ceftazidime, avibactam. Alternatively, cefiderocol. What is the role of tigecycline or irawacycline? So in bloodstream infection and urinary tract infection, avoid these two drugs because these two drugs have very rapid tissue distribution and hence limited concentration in your urine as well as your serum. But it is a very good drug if there is intra-abdominal infection. And where in that situation you can use hydroxycycline or irabacycline. One more thing for the contention was in pneumonia. In pneumonia, tigecycline, it was initially issued as a black box warning by the FDA. But later studies have demonstrated that it can be used. So the usual dose of 100 mg BD is not good enough. So you'll have to use a higher dose of 200 mg. What is the role of polymyxin B and colistin? The guidance has retained the previous stand that polymyxin and colistin are not suggested for the treatment caused by CRE. So what is the likelihood of emergence of resistance of the CRE if you are using the newer BLBLI? This is something new they have added in this. So the available data suggests that the frequency of resistance is highest with ceftazidime avibactam, and this is the situation we are going for now. As we all know, the ceftazidime avibactam was under the license. Now, after 5 years, it has the license has been lost, and there are various generic formulations which has come up now. So this is a big challenge for us. And it's not like ceftazidime avibactam is a magic drug. Even in CREs, which are non-MBL producer, there is various mutations which have already appeared, and there is increasing resistance, as well as we all know, our isolates of E. coli. They are apart from being MBL. Even there is a synergy. So ceftazidime avibactam with aztreonam synergy is also not being demonstrated because of the additional mutation, that is the PBP3 inserts which are there, making aztreonam ineffective in the combination. Hence, we'll have to properly utilize this antibiotic and avoid the misuse of this antibiotic. For further details about why we are using this combination, what are the implications of this combination, I have discussed in my previous other webinars. You can please see that. Next topic is the Pseudomonas aeruginosa with difficult to treat resistance. So the various categories of Pseudomonas aeruginosa. So there is MDR Pseudomonas, implying resistance to more than one agent in more than equal to 3 categories. Then we have difficult to treat Pseudomonas. By definition, it means non-susceptibility to all of the following commonly used anti-pseudomonal agents, that is your ceftazidime, cefepime, piptaz, aztreonam, meropenem, your carbapenems, as well, and your fluoroquinolone. Extremely drug resistance is resistance to all of this, including your newer BLBLI. The resistance mechanism in Pseudomonas aeruginosa, like in case of Enterobacterales, the carbapenemase was predominant, but when you look at Pseudomonas, it is other mutations like your foreign and efflex pumps which are more common than your carbapenemase. But again, even in India, there is increasing carbapenemase production, including the MBL production. So this one I've already discussed in my previous webinar. So efflex pump mediated mutations, as well as your foreign channel mediated mutations. So how do you identify? Also, I have discussed previously. So here I have a case, a 53-year-old male, known case of diabetes, coronary artery disease. He had underwent stenting 11 months back. Now he has come to emergency with high-grade fever, chills, rigors, and burning micturations for past 1 month. On examination, he has multiple small subcutaneous nodules over the trunk and the thighs. He was initially started on ceftriaxone, thinking he is in sepsis. Lab showed raised TLC, which was neutrophilic predominant. ESR is elevated 120. Procal is very high, 70. USG abdomen shows evidence of pyelonephritis, but there is no bilateral pyelonephritis, but there is no obstruction. Blood and urine culture shows Pseudomonas aeruginosa as shown. So what would you like to give in this patient? So please put up in the chat box. What would you like to start? Would you like to give ceftazidime, cefepime, meropenem, piptaz, or ceftazidime, avibactam? So if you see previously, the isolate is susceptible to your ceftazidime, cefepime, piptaz, but resistant to your carbapenems, but susceptible to your cefta-avi. So let's see. Piptaz, cefta-avi, piptaz, cefta-avi, ceftazidime, avibactam. So for this, you need to understand how to identify the resistance type. So again, as I mentioned, porine type, efflux type, and others. So as Pseudomonas aeruginosa, as such, wild isolate has low expression of the AMC. So some of your that is why you won't be reporting ceftriaxone, or you won't be reporting the first and second generation cephalosporins and Pseudomonas, because these are constituently or intrinsic resistance. There can be hyperexpression of AMC where your ceftazidime, cefepime, piptaz, or imipenem will be resistant. Then we have something, we have the porine mediated resistance or porine channel mutation. So this is very important to remember. In porine mediated resistance, you will be seeing resistance to your carbapenems, but susceptible to your lower BLBLI, like beta lactams, lactose, ceftazidime, cefepime, piptaz. So you can still use these drugs, and it's not like these are resistance, and because it is carbapenem resistant, you can't use the other beta lactams as well. Then we have the efflux mediated, pump mediated resistance, where there will be resistance to your lower beta lactams like your ceftazidime, cefepime, piptaz, but susceptible to your imipenem with plus or minus resistance to your meropenem. Then we have the production of carbapenem is, we have non-MBL and MBL. When will you think it could be an MBL producer? When you're seeing it is resistant to most of your all of your newer BLBLI, then we'll be looking, or you'll be suspecting it could be an MBL producer. So coming to the guidance. So in this guidance, they have mentioned that treatment for MDR Pseudomonas aeruginosa, which was not there in the previous. So the previous guidance was only for your DTR Pseudomonas aeruginosa. So coming to the treatment of MDR Pseudomonas aeruginosa based on the susceptibility. So suppose it is susceptible to all, or it is pan sensitive. So what is the drug of choice? So in this drug of choice, based on the antimicrobial stewardship as well as that susceptibility, it is ceftazidime. Next, what is this? This type of resistance. So as I have shown before, it is resistant to carbapenem but susceptible to your ceftazidime, cefepime, piptaz. So this is a porine mediated resistance. So the treatment of choice in this case is high dose extended infusion ceftazidime. So that is 2 gram Q8 hourly over 3 hours is the treatment of choice for our isolate. Then one more thing they've added is, if the patient is critically ill and it is even this porine mediated resistance and there is poor source control, the treatment of choice is your newer BLI. And always in Pseudomonas aeruginosa, or ideally all of your CREs, but especially in Pseudomonas aeruginosa, you will have to keep repeating the cultures as well as the AST. On treatment, the patient can go for the isolate can become resistant. So coming to the treatment of DTR Pseudomonas aeruginosa, recapitulating what is DTR Pseudomonas aeruginosa, difficult to treat resistance in Pseudomonas aeruginosa is defined as resistance to all of your lower beta lactams like ceftazidime, cefepime, piptaz, carbapenems, as well as your fluoroquinolones. So in uncomplicated cystitis, the newer BLBLI. So in this the order will be ceftriaxone tazobactam is preferred in Pseudomonas aeruginosa. Why? Because ceftriaxone as well as ceftazidime may have similar structure, but ceftriaxone has intrinsic activity against your Pseudomonas aeruginosa. That is why it is preferred as then in case alternative that has been provided a single dose of tobramycin or amikacin. So if you remember this year's, if you have read the recent CLSI, the update is they have changed the breakpoint for aminoglycoside for your enterobacterials as well as Pseudomonas. In Pseudomonas, the breakpoint for your gentamicin has been removed, and in your aminoglycoside, the breakpoints of amikacin is there only for your urinary isolates and not for your other isolates. And if all of these are not possible, then you can go for colistin. In case of uncomplicated cystitis, polymyxin B is not preferred. There is no role of fosfomycin in Pseudomonas aeruginosa. Then in case of pyelonephritis, ceftriaxone, tazobactam, newer BLBLI. In case of infection other than UTI, again your newer BLBLI like ceftriaxone, tazobactam, ceftazidime, imipenem, relebactam. Alternatively, you can use cefiderocol or full dose of your aminoglycoside, that is tobramycin or amikacin. So if you observe closely amongst the newer BLBLI, which is the newer BLBLI you're not seeing in this chart? Anyone? Which is the newer BLBLI which is missing in this? Okay. So you can't see your meropenem veibourbactam anywhere. Okay. So because the studies have also proven that there is no added effect of using meropenem veibourbactam because your veibourbactam component does not have any good or additional anti-pseudomonal activity. So it is as good as giving just meropenem. So that is why there is no CLSI breakpoint or no recommendation for using meropenem veibourbactam in Pseudomonas aeruginosa. So continuing with the case, the patient continues to have fever spikes, blood cultures were repeated and it is growing Pseudomonas aeruginosa. And when you examine the patient, you are seeing these in the nails there are some things, and in the hands there are something. So what are you seeing in this? What are you looking at now? What is the syndrome you're looking at now? Anyone? Yes, infective endocarditis. So one more thing. So there was red flags in the case, but from beginning the patient had no instrumentation. So is Pseudomonas aeruginosa a common organism in UTI? Obviously no. Source of your Pseudomonas aeruginosa, the patient had a CAD prior. That is CAD stent prior. So any foreign body in the patient can be a site of your sanctuary for your biofilm forming organisms like the Pseudomonas. And whenever the patient is having continued fever spikes and blood cultures are repeated and it is still persisting positive, you will have to look at or think about infective endocarditis. So 2-day echo was done and there was a vegetation 6 into 4 mm in the mitral valve. Repeat blood culture showed Pseudomonas aeruginosa, and now we have this susceptibility. So again, I forgot to tell what was it that the lesions which you saw was the splinter hemorrhages in the nails and Janeway lesions in the palm. Okay, so the repeat culture has showed this one. So this is why it is necessary that you keep repeating the culture and antimicrobial susceptibility in Pseudomonas, because on treatment the patient can undergo the newer resistance mechanism can develop. So what would you like to do this? What treatment would you like to give in this case? So again, Pseudomonas aeruginosa testing for carbapenems is not recommended, but it is because there is increasing resistance and increasing carbapenems production even in Pseudomonas, which has been reported. Ideally, you have to do it, and the same kit, that OKNIV kit, can be used for your fermenters as well as non-fermenters. So you can use that kit to find out whether it is an MBL producer or not. So coming to the guidance, so this time they've added treatment of choice for MBL Pseudomonas aeruginosa, and it is not ceftazidime avibactam plus aztreonam. So there has been studies. There are very, very limited studies which is available. The panel is suggesting that there is no added effect or incremental benefit of using ceftazidime avibactam plus aztreonam over using a single aztreonam or using with just using aztreonam. And there is a preliminary data available from aztreonam avibactam study which has showed that this combination may not be effective, and it can be effective only against less than 10% of the MBL. So what are we going to use then? So cefiderocol can be used, and in countries like India where we don't have the availability. So next is the combination therapy. So ideally combination therapy, the guidance suggests against combination therapy. Even in case of DTR pseudomonas, the combination is not suggested if the susceptibility is demonstrated. But if there is no susceptibility demonstrated, like in our case, it's a MBL, so you can use combination that is your tobramycin plus your BLBLI or your cefiderocol. If the tobramycin is also resistant, then you can go for polymyxin B plus your BLBLI. Again, there is. So this is a summary of the treatment. What's new? So I will be skipping that. Next, we have a case. A 58-year-old female, COVID positive. She was asymptomatic. She was admitted in COVID-19 isolation and was treated with steroid and remdesivir. And prior in 2000, so she developed progressive worsening. Initially, she was put on low flow oxygenation with Venturi mask, and later she required NIV with ICU admission within next 24 hours, and this was continued for next 5 days. So there was worsening breathlessness with desaturation requiring intubation with mechanical ventilation on day 9. From the ET. And in the growth, there is Acinetobacter, which is carbapenem resistant, and CRE, Klebsiella. And this is the chest X-ray. As you can see, there is worsening, there is increasing shadows. So I have few questions now. So what should be done now? Should we treat the CRE? Should we treat the crab? Is crab a colonizer? Should we treat both? So if we have to treat both, what antibiotic should be used? Can we use ceftazidime avibactam in this? And is there any other test which requires to be done? So anyone who are all for treating only CRE? Please comment. Please put in the chat box. Both. Anyone for only CRE? Repeat culture. Both. Yeah. So yes, there is increasing evidence that even your crab, though it could be the colonizer, but there is higher mortality which is associated, especially in this patient where we are having all the features suggestive of VAP. So now you want to treat both. It's a CRE and crab. So if I just give ceftazidime avibactam, will it cover both? So suppose the CRE is a non-MBL producer. So I'll give ceftazidime avibactam. Okay, maybe MBL also with aztreonam. So will it cover both CRE and Acinetobacter? Yes or no? Please comment. Yep. No? No? Yes. So those who have answered no, I'm thankful. Hopefully it is because with previous I have talked about the various newer BLBLI. So important, ceftazidime avibactam with or without aztreonam. No, if there is all of them are intrinsically resistant to your Acinetobacter, so it cannot be used for your Acinetobacter. So what are the additional tests for CRE? For identification of type of CRE, you should go for the carbapenemase testing. So whenever you're isolating crab in culture, you'll have to look at whether it's a, always look Acinetobacter with a doubtful eye, whether it is just a colonizer. So especially if it is from non-sterile sites like airway, lungs, skin, it can colonize easily. So in that case, next you'll have to look at whether there is signs of infections like that is fever, increased WBC, raised inflammatory markers, and abnormal imaging. If all these features are present, then you will be treating. If there is no signs of active infection, you can just observe. If the isolation is from the sterile site like your blood, CSF, pleura, UTI due to Acinetobacter is very rare. So again, that also you will have to consider. And next, you have to look at whether there is a presence of any indwelling catheter or indwelling device. If there is indwelling device like your CVC, EVD, chest tube, then look at whether signs of infection is present. If there is no signs of infection, observe, replace the device. That is the first and foremost. If there is signs of infection, you can start the treatment with the replacement of the device. If there is no indwelling device, mostly it is significant infection, you will have to treat. So what are you going to give the treatment in case of CRAB? So the management of CRAB is difficult because, as we all know, it is mostly isolated from your respiratory specimens and wound. So you can't ideally differentiate it's a colonizer or a pathogen. And most of these are carbapenem resistance, and there is multiple methods or the multiple modes of resistance acquisition. There are OXA 2440 carbapenemases, NBLs, including serine carbapenemases. Even other resistance like aminoglycoside as well as fluorophore resistance is there. Then there is no clear standard of care antibiotic regimen for CRAB. So even if there is newer drugs which is developed, there is no way we can compare the newer regimen against any stand because there is no standard of care. So what is the general approach? So CRAB infection, initially this was a last year's guidance where they are divided into mild infection and where mild infection in the case of that is your UTI, skin and soft tissue infection, tracheitis. So there they are preferred ampicillin. Even if the ampicillin sulbactam is resistant, you have to give high dose ampicillin sulbactam. In moderate to severe infection, combination therapy with at least 2 agents with in vitro activity, in which you shouldn't be using fosfomycin or rifampicin, and there is no role of nebulized antibiotics for CRAB pneumonia. So this guidance, they have restricted themselves to moderate to severe infection due to CRAB and not commented upon the mild infection. So why should we use combination? So they're strongly recommending combination therapy in moderate to severe infection of CRAB, even if there is susceptibility demonstrated, because there is lack of robust clinical data supporting the treatment of CRAB with a single agent. Then next, most of the patients who are developing CRAB infection, they are usually hospitalized for a long time. There will be on so many empiric antibiotics. So we expect very high burden of bacteria in these organisms. And these empiric antibiotics, the patients are treated. What are the treated? Ceftriaxone, your vancomycin, etc. will not cover your CRAB. And these patients are chronically and critically ill with potentially impaired immune system, and antibiotics which can appear susceptible now can rapidly develop resistance because, as I have shown before, there is multiple methods or multiple modes of antibiotic resistance. So what combination you should give? So irrespective of what combination, your ampicillin sulbactam should always be present. And why are they telling only about ampicillin sulbactam and not cefoperazone sulbactam? One, availability. As I mentioned before, this is US-based guidelines. So there they don't have cefoperazone sulbactam, so it is not being commented upon. Next, don't have single or plain sulbactam which is available. That is why they are giving this combination of ampicillin sulbactam. In India, we have the plain sulbactam which is available. So if it is ampicillin has no additional benefit in CRAB, so if you can give ideally give only plain sulbactam can be given, and we are using the same. And this should always be a part of the combination regimen, even if the resistance has been demonstrated. Next, in this combination, next ideal thing is your tetracycline derivatives. Minocycline is preferred over your tigecycline. Then your polymyxin. So what you should you give a dual therapy, triple therapy? So dual therapy, that is ampicillin sulbactam plus minocycline, is a good treatment. If the susceptibility is not demonstrated to your minocycline, then polymyxin B can be added to the combination. And the specific mention, do not use polymyxin B plus meropenem without a third agent. So why are we giving sulbactam? So sulbactam is a competitive and irreversible beta-lactamase inhibitor. And in high doses, it will saturate the PVPs, that is PVP1 as well as PVP3. You have to give high dose, that is 9 overall ampicillin sulbactam 9 gram, or if you are giving plain sulbactam 3 gram Q8 early over 3 to 4 hours, or you can give 27 gram IV Q24 early as a continuous infusion. And this has known to show reduced mortality, reduced nephrotoxicity. So this was the flowchart which was I had made for the previous IDSA guidance. So this time, as I mentioned, this mild infection part has been removed, and they are commenting only on the moderate to severe infection. So based on that susceptibility, for first line susceptible, yes, you can use a combination of two agents. So the preferred combination is ampicillin sulbactam with minocycline first, then or tigecycline. If not, otherwise polymyxin B. Is there a role of triple drug therapy? The studies have shown that there is an in vitro evidence that the triple therapy, that is your polymyxin B, meropenem, minocycline, ampicillin, polymyxin B, meropenem plus your minocycline, or the combination triple therapy is effective. But this is a question to be answered. And is there a role of polymyxin B single or monotherapy? So because the guidance is mostly for moderate to severe infection, they are not recommending polymyxin B as a monotherapy, but only in combination. And what is the role of tetracycline? And as I mentioned, they are not talking about mild. In the previous guidance, they had mentioned that for mild infection, you can use monotherapy, but this guidance does not address the mild infections. So which tetracycline derivative? Minocycline is preferred over tigecycline just because there is long-standing clinical experience and CLSA interpretation is available, and we have to give high dose minocycline, that is 700 mg loading dose followed by 350 mg Q12 early than the standard doses. High dose tigecycline is an alternative, but it should not be used in your bloodstream infection. So what is the role of extended infusion? Previously, they were recommending extended infusion, but this guidance they suggests there is no role of high dose extended infusion. And as I mentioned, the combination of polymyxin B plus meropenem without a third agent is not recommended. So is there a role of nebulized antibiotics? There is no role of nebulized antibiotics for CRAB, Pseudomonas, CRE. They are not in favor of any nebulized antibiotics because parenteral formulations are not specifically designed for inhalation, lack of benefit observed in the clinical trial, concerns about the unequal distribution in the infected lungs, and concerns of respiratory complications like bronchoconstriction. So that brings us to the end of the treatment, the AMR IDSA updates. So if you have any queries, please put up in the chat box. Or you can unmute yourself and ask any questions if you have. And I'll be leaving the feedback form link in the chat box. I request all of you to kindly fill the feedback. So anyone would like to talk or any comments or any questions, please unmute yourself. And I have not covered Pseudomonas, which has also been addressed in this. because of the time constraints, I think it's already, yeah, so I wanted to wind up in an hour. So cefoperazone sulbactam with EDTA. What is the role of cefoperazone sulbactam with EDTA? There is no one of the papers has been also said previously. I've discussed that there is a combination with EDTA. Theoretically, EDTA is a chelator of your MBL. So theoretically it should work, but the formulation which is available, so some of the places this is available. Ceftriaxone sulbactam EDTA is available as LORIS, and I am sure many of you might have tested as well, and you may have been seeing susceptibility. But the dose which is the EDTA which is present in the disc does not translate to the formulation, and the dose which is required of EDTA which is required to properly inhibit the MBL in case of your CREs may not be sufficient, and if you give higher doses, maybe the patient will have other complications. So that is why it's an irrational combination. Please don't go for it. Please advise the clinicians against using this combination. Basically, all these are your most of these physicians, based on the pharmacy representatives, how lucratively they explain the drug, they'll be using it. So let's see here. In critically ill, non-neurological indication, what are the using? Okay, what are you using? 2 gram TID or 1 gram TDS? So I mean, if the patient is not critically ill, we are using 1 gram TDS extended infusion, that is over 3 hours. It is as good as giving a higher dose. So make sure everywhere beta-lactams, that is the carbapenems, are being used as an extended infusion. And if the patient has a like any abscess or the source control is not proper, like complete source control is not proper, you can go for higher dose 2 gram TDS. In case of AMC organism causing UTI, which drug to be used best is cefepime or meropenem? How good is cefepime in UTI? Cefepime can be used, but again, based on the MIC, I think most of the isolates which we have seen are having higher MIC, and it's so we would go for the carbapenem. In general practice, we are using carbapenem only rather than your cefepime, because I was being a tertiary institute, most of the cases we get are like prior multiple antibiotic exposure and the patients are critically ill. So next, how to check for just 1 second. How to check AMC production in Pseudomonas and Acinetobacter? AMC is intrinsically produced by your Pseudomonas, so you don't have to look at AMC. They will have some low-level AMC production, which will always be there. So don't specifically test for these. Then amoxiclav, if it is coming sensitive, then can we use in UTI? As I mentioned, amoxiclav don't use in CI, ESBL, AMC, etc. It's enterobacterial infection. But if it is, suppose it is your enterococcal infection, it can be used. It has a good urinary concentration, so much that they suggest that even if it is coming resistant, it can be used in your enterococcal urinary tract infection. So can we apply fosfomycin as step-down therapy based on forest trial? So forest trial, they have looked at fosfomycin, IV fosfomycin in MDR E. coli infections, and there are certain points which are of concern in that. One thing is, most of the patients which we are seeing is critically ill, and the IV fosfomycin which we are going to give is causing a lot of, they will have to give a lot of fluids, which is causing overload, and the patient can end up in failure. So, and IV fosfomycin availability is very limited in our settings here. Oral fosfomycin is a good option for a step down therapy in case of your cystitis. I wouldn't use even oral fosfomycin as step down in pyelonephritis. So, any more questions? Can we end it here then? So anyone wants to talk or anyone wants to ask any questions? You can unmute yourself and talk. Okay. Okay. So if you have any queries, please feel free to leave in my either Telegram account, or most of you may have my WhatsApp. So you can, or leave it in my email ID. So I'll try to address it. And in the Google form, I have also mentioned. So I'm planning the next debate series. So please give your opinion or any topics which you think is necessary to be discussed. Please respond and please fill the feedback form. It will help me to take the feedback and improve upon it. I hope this time there was no audio and network issues, because I think that was the most common feedback, negative feedback I have got. Okay. Okay, let's end it here then. Thank you. Thank you everyone for joining on Sunday evening.